The topic I chose to discuss for this project is healthcare policy. Most specifically, I'm going to be talking about the issues of cost, access, quality, and the diverse ways that government activities affect the public's health and its well-being. First, I will discuss a little bit of background. Healthcare policy is described as all actions that government takes to influence healthcare services, as well as various activities that affect public health. And I got this out of our Craft and Furlong text on page 261. Most simply, it is the design and implementation of the range of federal and state programs that affect the provision of healthcare services, including Medicare and Medicaid. Healthcare policy regulation by government is relatively recent. However, some public health agencies have been around for a while, but I'll talk about those in the next slide. The modern concept of healthcare involves access to medical professionals from various fields, as well as medical technology, such as medications, surgical equipment. It also involves access to the latest information and evidence from research, including medical research and health services research. Public agencies are a big part of government healthcare policy, and they've been around for quite some time. The three that I'm really going to talk about today are the FDA, the NIH, and the CDC. And these public agencies, they were originally implemented to combat infectious diseases. So they do things like provide safe drinking water supplies, sanitation, waste removal. But more specifically, so the FDA, or the Food and Drug Administration, regulates food, drugs, vaccines. They label cosmetics, medical devices, contact lenses, and even radiation in consumer products such as your microwaves and cell phones. So regulation by the FDA is based off of three subjective qualities: current uncertainty, asymmetric observability of error, low reversibility. So what inherent uncertainty is the FDA officials know that even the most successful clinical trials cannot eliminate the possibility that a drug will turn out to be unsafe or inefficacious. And I got this straight from the Food and Drug Administration website, their government website. And that's basically because no pharmacology active drug substance is entirely free of risk. The conclusion that a drug has been shown to be safe for use is actually no more than an opinion. And so risk to benefit assessments are arguable. All the more so because each turns not only on personal sentiments, but the nature of risks and benefits of a drug. So basically what that means is it's an opinion, and they take a vote based on incomplete and imperfect information concerning the drug's risk. But if they believe that the benefits outweigh certain risks, it could still pass. That's not to say that there isn't any risk. And like I said, I got that right from the U.S. Food and Drug Administration government website. So asymmetric observability of error. For most of the FDA's history, errors have been pretty visible. As the remarks from one of the former commissioner illustrates, that the FDA has often been excoriated for approving a bad drug or approving it too quickly, but only recently has it been criticized for approving drugs too slowly. So basically, they have been accused of approving drugs without enough research, and they've been approving them too quickly, and that's why they end up with recalls and certain side effects. So the low reversibility is stating that the damage of a faulty approval is difficult to undo. So the FDA can always secure a recall of a faulty product or ask the manufacturer to attach a black box warning, yet it kind of publicizes the error that the agency has made. So even though drug approvals are reversible, the FDA views drug approvals as irreversible based on a reputation standpoint. Based on that information, you could see why the FDA is under extreme scrutiny for their drug approvals as well as the drugs they have not approved. So next, moving on to the NIH, or the National Institute of Health. What it provides is health research across the nation. It's the largest public funder of biomedical research in the world. It invests more than $30 billion from taxpayers a year to achieve its mission to enhance health, lengthen life, and reduce illness and disability. In pursuing this mission, the NIH improves health by promoting treatment and prevention. It contributes to society by driving economic growth and productivity, and expands the biomedical knowledge base by funding cutting-edge research and cultivating the biomedical workforce. And I got that straight from the National Institute of Health government website. That's their mission. The next agency that I'm going to discuss is the CDC, or the Communicable Disease Center. And what it does most basically is it works on development and application of disease prevention, immunization, prevention and control of AIDS and other infectious diseases, chronic disease prevention, birth defects and developmental disabilities, occupational safety, and it compiles a great deal of health statistics for the government. Moving on, we can talk about the evolution of healthcare policy. So I'll go in a brief little history here. In the years following the Civil War, hospitals became either private or public, so one or the other. Earliest efforts of doctors to create a professional organization started mid-1800s, and that was the American Medical Association. It had little early impact on American medicine, but by the next century, they had great influence over politics and practice of medicine. So you can see that the government and politics has had a bit of say in healthcare for a very long time, even if was not as prominent as it is now. So the first victory of the AMA was the regulation of drugs, and I got that from the Fillmore article. As the 19th century ended, advancements in biology and other sciences meant that the great diseases such as tuberculosis, yellow fever, diphtheria, cholera, and I'm sure I'm forgetting a couple other, but they were practically eliminated with the development of vaccines and other diagnostic tests. Extensive public health projects aimed at fighting the causes of these diseases or prevent their spreading. So about 1930 was the first time health insurance could be taken out, and it only covered catastrophic losses. After that, the Social Security Act was presented Medicare and Medicaid programs, and that was in order to cover those who could not formally get insured based on pre-existing conditions and other circumstances. Excuse me. The U.S. healthcare system is very different from other healthcare systems, as we still have it single payer insurance, which is where the government pays. And then most recently, we have the Affordable Care Act. which is highly controversial and complex. But what it does is it expands Medicaid and children's health insurance programs, mandating that everyone has health insurance. It subsidizes cost of insurance for low to moderate income families. It offers tax credits to encourage business people to provide health insurance. It created a bunch of new regulations, including that children that are students can stay on their parents' plan until they're 26 years old, and it will eventually cover individuals with pre-existing conditions. Now, this act is to take effect over the course of 7 years. So some of these policies have already been implemented, but some of them are still yet to come. So the United States healthcare system, it does have many strengths and weaknesses. Some of those strengths include that we are able to offer a high quality services for those with good insurance. We are at the forefront of clinical research. We've had numerous breakthroughs in diseases. And we have a large number of physicians, especially specialists. And I got that from Comparing Healthcare Systems, and that's from 2011. The weaknesses are quite extensive. 15% of our population has no health insurance or coverage, and that is the highest in the industrialized world. The cost of healthcare is the highest per person in the industrialized world and is growing the fastest. The United States health outcomes compare poorly with those of other developed countries. So just to name a few, we are 20th in the world in infant mortality, or 29th in low birth weight babies, and we're 6th in life expectancy. Many individuals and small groups are denied insurance primarily because of pre-existing conditions or really high premiums. To shift costs, hospitals charge smaller payers more in order to make up for the uncompensated costs from the uninsured and reduced fees by larger payers. Hospital marketing jobs in the U.S. increased 71% and administrative jobs 20%, but the clinical workforce has not expanded since 1989. The U.S. has more physicians per capita than most other industrialized nations, but they are distributed unevenly, both geographically and by specialty. Office-based primary care physicians have nearly disappeared in low-income areas. Financial incentives encourage expensive high-tech diagnosis, treatment, and specialization, and there's not enough primary care. And I got that list of weaknesses from the Comparing Healthcare Systems as well, 2011. Two major healthcare programs are Medicare and Medicaid. We'll go ahead and Medicare was originally intended to help those 65 and older, but now it includes those under 65 with permanent disabilities, those with diabetes, and end-stage renal disease. There are two parts to Medicare. Part A is the core part, and it partially covers hospital charges, 100 days in nursing care following hospital release, individuals eligible for federal security system and railroad retirement benefits. It covers them as well. Part B is optional. It's supplemental for things other than hospital stays, such as physician charges, diagnostic tests, outpatient services. It has deductible and co-payments, and it also covers yearly wellness visits. It uses so Medicare uses a fee schedule of reasonable costs that specifies what health professionals are able to charge. Many physicians choose not to participate because they think the cost is too low, so you could be limited on what physicians you may seek services from. And moving on to Medicaid. Medicaid is designed to assist the poor and disabled through federal state program of health insurance. The government established standards for hospital services, outpatient services, physician services, and lab services. It covers half of the cost, so individuals are responsible for the other half. It's required to be extended to welfare recipients and supplemental security income recipients. It's the most costly program in a state's budget, and I got that from the Medicaid Expansion Gap article. So veteran healthcare is also a healthcare system that's offered. So it's primary, specialized, and other medical and social services, as well as rehabilitation for veterans. In many areas of the country, several medical centers and clinics work together to offer services to area veterans as a healthcare system in an effort to provide more efficient care. By sharing services between medical centers, healthcare systems allow organizations to provide veterans easier access to advanced medical care much closer to their homes. Medical centers provide a wide range of services, including traditional hospital-based services such as surgery, critical care, mental health, orthopedics, pharmacy, radiology, and physical therapy. In addition, most of our medical centers offer additional medical and surgical specialty services, including audiology and speech pathology, dermatology, dental, geriatrics, neurology, oncology, podiatry, prosthetics, urology, and vision care. Some medical centers also offer advanced services such as organ transplants and plastic surgery. A subsect of veterans healthcare is TRICARE, and this includes retired veterans that have retired in the last 20 years. It pays for most of the costs not covered by Medicare, and I got that from the VHA website within the government. Many think the addition of TRICARE was just a political stunt in an election year, many stating that if Medicare is not good enough for military men and women, what makes it good enough for those that have paid a lifetime of federal taxes? And that's from the Brookings Institution. State policy innovations are also becoming increasingly popular. Typically, healthcare policy is up to the federal government, but more recently, state governments have adopted initiative policies. An example includes California with their smoking reform. They raised their taxes on cigarettes in order to prevent smoking within the state. And then here I have a link on state expansion of Medicaid. If I can bring it up here. And this here is a Medicaid expansion map, and it shows all of the states that are expanding their Medicaid services. So over here in the legend, you can just hover over each state to see where they are. So, for example, in Illinois, they're expanding Medicaid. In Indiana, they approved customized Medicaid expansion. In Montana, they did the same. Texas, that they are not expanding. So, and it explains the impact. So, 766,000 people are not covered. They land in that gap, and there's a loss of 9,217 federal dollars. So another example, Colorado, they are expanding. Missouri is not expanding. And so as you can see, they're not going to lose quite as much as Texas, but it lists the number of people in that coverage gap. So I just thought that was kind of interesting that states are taking more of a responsibility in healthcare and expanding their services. We'll go back to the PowerPoint. And then moving on to preventative care. So what preventative care is, this includes routine screenings, education, and more attention to health risk factors. Those routine screenings include diabetes, cardiovascular disease, and high blood pressure. And the health risk factors include diet, exercise, smoking. So the health risk factors include diet, exercise, smoking, and other lifestyle choices. The lifestyle risk factors that are related to illness and premature death include diet and smoking. So there's some criteria that is used to determine how the risk factor is correlated to illness and death, and that is effectiveness, economic efficiency, and equity and other economic issues. So under preventative care, the CDC actually has a few goals to improve preconception health. So number one is to improve the knowledge and attitudes and behaviors of men and women related to preconception health. Assure that all women of childbearing age in the U.S. receive preconception care services. That will enable them to enter pregnancy in optimal health. And that includes evidence-based risk screening, health promotion, and other interventions. Number three is reduce risks indicated by a previous adverse pregnancy outcome through interventions during the interconception period, which can prevent or minimize health problems for a mother and her future children. And number four is reduce the disparities in adverse pregnancy outcome. So you can see that preventative care is expanding to not only everyday things such as high blood pressure and diabetes, those chronic diseases, but also to ensure that we have better pregnancies and other lifestyle choices are made easier. So we'll go through that criteria next. So effectiveness of preventative care. Prevention can reduce the significant economic burden of disease in addition to improving the length and quality of people's lives. Treatment, lost productivity, and healthcare costs are significant burdens to the economy, families, and businesses. Prevention policies and programs are cost-effective, reduce healthcare costs, and improve productivity. The next criterion was economic efficiency issues. So here I just have a graph of cost barriers to the use of preventative services for men and women. So it shows you here just why people do not participate in preventative care, and oftentimes it's because they foresee it as too expensive. But if they did receive this preventative care, it would often cost less in the long run because it could potentially prevent a chronic disease, cancer, or some other illness that maybe doesn't have any symptoms right away. And so what it's talking about here is that prevention lowers healthcare costs. So, and I have a few just little facts on that. So for every HIV infection prevented, an estimated $355,000 is saved in the cost of providing lifetime HIV treatment. A proven program that prevents diabetes may save costs within 3 years. 1 of every 5 U.S. healthcare dollars is spent on caring for people with diagnosed diabetes. People who increased their activity by 2.5 hours a week and had 5 to 7% weight loss reduced their risk of developing type 2 diabetes by 58%, regardless of race, ethnicity, or gender. And a 5% reduction in the prevalence of hypertension would save $25 billion in 5 years. So those are just a few little facts, and I got those from the... So as you can see, those small lifestyle changes and preventative measures could save the country thousands, billions even, in healthcare costs. And I got that information from Health Literacy and Preventative Healthcare Use Among Medicare Enrollees in a Managed Care Organization. And from there we will move on to ethical issues. Should the government be able to regulate lifestyle choices? That's very controversial. Some would agree that smoking is a choice. Everybody knows it's bad for you, but it's still your choice whether or not you do it. So prevention is also known to increase productivity. So indirect costs to employers of employee poor health, so lower productivity, higher rates of disability, higher rates of injury, and more workers' compensation claim, can be 2 to 3 times the cost of direct medical expenses. For example, asthma, high blood pressure, smoking, and obesity each reduce annual productivity by between $200 and $440 per person. So preventative health can also save you in labor supply by reducing sick days and missing time from work. And I got that from the Economic Benefits of Preventing Disease. And ethical issues. Should the government be able to regulate lifestyle choices? I guess this is the real debate here. It's very controversial. Some people say that it is your choice to, for example, smoke. Everybody knows that smoking is bad for your health, but if you would like to do it, that is your choice, and the government should not be able to regulate those lifestyle risk factors, seeing how they impact you. So it's quite interesting. We're kind of going through that on our campus now as the Red Hawk Health educators try to push through a ban on tobacco across campus. So we'll see how that goes, and we may get to see how that plays out. So the last thing I have is the question of what is the real issue with the United States healthcare policy. Healthcare costs are on the rise. Baby boomers are aging out and leaving us the next couple generations with nothing. and it's in need of a change. And what that change is still up in the air research-wise, but everyone knows that one does need to happen because with the high costs, we will soon bankrupt.